So my name's Emily Thompson. I am a transplant surgeon and a clinical lecturer based here in Newcastle. So I've been involved in this research for about 10 years now, and I am the chief investigator of the study. The research that we're proposing is born out of the new developments in transplantation where we machine perfuse organs. And that's a really unique situation where we have an organ alive outside the body being pumped with blood and oxygen. And we've been doing that for the last few years in transplantation, and it's meant that we've been able to transplant more organs. But it also provides a really unique opportunity where we can treat the organ before it's transplanted. So we could consider, for example, a cell therapy or a gene therapy to make that kidney or that liver better before it goes into the recipient. And that's a really exciting new area of research, and it's something that a lot of the transplant community are really excited about. But we need a test that tells us whether or not our treatment has worked and whether or not that organ is now transplantable.
So my name's Colin Wilson. I'm a professor of transplant surgery based here in Newcastle. I've been working in transplant surgery for 25 years now, and I perform liver, kidney and pancreas transplants as well as surgery for cancer. My research interests are all around assessing and treating organs for transplantation. So the concept is the organ, instead of going straight to the transplant centre, it's taken to a repair centre where it's tested, it's assessed in some way. This is where our test, the 6-gene signature, comes in. And then it's given either a cell therapy, a drug treatment, or a gene treatment, or maybe all three, to improve the underlying quality, improve the resistance to damage, or just get rid of the damage that's been incurred, and then taken from that centre to the transplant centre. So we're creating this new hub in the middle of the current pathway to just improve the outcomes from the recipient's perspective. And hopefully it'll make my life easier as well, that I don't have to take risks, that I know that this organ's going to work. And it's just better for everybody, both the healthcare system, the recipients, the surgeons. It works on many different levels.
I'm Neil Sheeran. I am the Professor of Nephrology at Newcastle University. So I've been involved in the work that's led up to the 6-gene project. For the last 5 or more years, we've been working on ways of improving the quality of donor kidneys before they're implanted into the recipient. And that's a program of work that's been running, as I said, for 5 or so years. So the 6-gene signature is almost an extension of that work, looking at ways of assessing the quality of the kidneys that we've given novel treatments to ensure that they meet a sufficient quality to allow them to be used for transplantation. We hope at the end of this project we will have a test, or more likely a battery of tests, that we can apply to a kidney to show that our intervention has worked and that the benefit of that intervention persists and moves kidneys that have perhaps previously untransplantable to a position that they're transplantable, and to make transplantable kidneys better. This will not be for all transplants, because many transplants will be very good anyway, and we won't need to apply these therapies. They can be transplanted straight away. But it's those kidneys that there's uncertainty, the more marginal kidneys, that these sorts of tests, these sorts of therapies will potentially be very beneficial for. And that's really the focus of this project.
So the aims of this research are firstly to validate the 6-gene signature in the kidney transplant cohort, because we've got good information on it in liver, and now we want to look in kidney transplant. And we also want to look at potentially expanding it to include some other biomarkers in the signature. And then we want to take it further, and we want to look at how this test can help us in a reconditioning hub. So if we're going to be doing this test before we add in an advanced therapy like a stem cell therapy or a gene therapy, we need to know how it's going to react to that therapy. So we'll look at it before, we'll look at it after an organ's been treated, and then we want to look at it longer term to see if the effect persists. Our first plan for doing this research is to first look at a bigger sample cohort of kidney perfusion samples to validate the test. And then what we're going to be doing is taking organs for research and treating them with therapies and testing the test. So that will involve taking, say, a pair of kidneys. One kidney will get the therapy, be a cell therapy, a gene therapy, something similar to that we know already from our other research has the potential to improve that kidney's function, to take an untransplantable kidney to a transplantable kidney. But the other kidney, the sister kidney, will have no therapy. And here we will deliver the test. Well, we'll check the test before and we'll check it after. And then we will put the kidneys back into the icebox and send it to the other centre, where they will do a model of transplantation, and then they will test the test again, but they won't know what's actually been done to the kidneys at our side, so they'll be blinded, and it'll help us evaluate that.
So we've established with the research that we've done so far that the test is good at assessing inflammation in organs, both the liver and the kidney. What we're looking for in this set of experiments, this project, is to validate those results in a bigger cohort, but also test the concept of repair centres, of reconditioning centres. That hasn't been done before. And what we need to show is that not only can we treat organs in a centralised facility, but that treatment persists and actually is taken with it to the transplant centre. So we're looking to test both the test itself and the concept of treating organs in specialised centres and then taking them to transplant centres.
When we're thinking about delivering these sort of advanced therapies to kidneys before transplantation, that's going to take a lot of expertise and skills. And so the thought is that would need to be centralised in a reconditioning centre. We'll need to navigate, as part of that process, a series of regulatory hurdles, because this is the first time anybody's considered treating an organ ex vivo before it's transplanted. And there's decisions that we need to make about what sort of tests are going to be mandatory as part of that regulatory process. And that's where things like the 6-gene signature become important. So we're trying to do this research early in the process so we can navigate these hurdles as they're coming down the line before we develop this into the clinic. So we're trying to preempt what's required by the regulators so that when we go to clinical trials with these therapies in reconditioning centres, we have all the tools there ready to deliver this therapy. We envisaged that the 6-gene signature test would be used before we treat an organ with any sort of reconditioning therapy, after we've treated it to test if that therapy's worked, and then if that organ is going to another centre for transplantation, they could test that signature again to see if the reconditioning effect of our therapy has persisted.
Improving the quality of transplant organs and increasing the number of transplants we do, we have to accept is a really challenging area. It is critical that we do that. There are so many reasons why we should be doing it, but I don't think we can underestimate the complexity of doing that. What we're doing here is to address one part of that. We're generating a test or a series of tests that will allow us to show that kidneys are being improved. And what we want to see is that test being used in the future as part of a transplant pathway. That's really what we want to achieve. So as the concept of reconditioning improves and actually gets to the point where it's been applied to transplant organs that are being transplanted, allowing us to do more transplants, we want to see this test embedded within that pathway as part of that process. One of the other things about the reconditioning centre, and something that we will be thinking about in the context of this project, is how that the tests that we are developing could be used within the pathways developed within reconditioning centres. This test will be a very objective way of telling us more information about the quality of an organ, whether that organ is transplantable, how good it is, how long it's going to last. So that's what we're aspiring to. If the tests are used in the context of reconditioning centres, it will allow potentially some organs to be used that may not otherwise have been used, but also it may allow us to start to refine what we do in a way that means that we can say, actually, this organ may not be the best organ, but it may be suitable for someone who needs a kidney that's going to last 10 years.
Okay, so there's three things that we're looking for with the outcome. One is that the normal pathway doesn't change, so that the good organs, we don't change that. They just go direct from the donor to the recipient and be transplanted normally. We don't really need the test for those. And then at the other end, where the organ, for whatever reason, it's damaged beyond repair at the donor centre, then again, that doesn't change that much. But it's the big bulk of organs in the middle, the grey area, where we're just not sure. So in those situations, what we would hope for with the results of this research is that the organ is taken to a repair centre, a reconditioning centre. It's assessed as it comes through the door using the 6-gene signature test. It's treated with whatever advanced therapy we find is going to work in that situation, and then it's retested as it leaves the door on the way to the transplant centre, and we can show that the quality is improved, that the test shows us that we have the assurance that it's better than it went in, and then when it goes to the transplant centre, that repair is carried with it, that it's not lost along the way for whatever reason.
The ultimate aim will be that in the future we can take these possible marginal kidneys, give them a treatment, apply the test, say that the treatment has worked, and that kidney can then be used. That means that we can do more transplants, we can get more people off dialysis. And that's really the ultimate aim of all transplant research, is to get more kidney transplants performed and get those kidney transplants to last longer.